Hi, everyone. I'm very excited to be here with you all today. My name is Lauren Heller. I'm a talent partner at Norwest Venture Partners, supporting our venture and growth stage investments across healthcare software and services. I previously served as Chief of Staff to Dr. Sachin Jain at CareMore Health. At Norwest, we've been very focused on investing in value-based care models for several years, most recently at Diana Health in the women's health space, in addition to companies like Monogram and Clever Care. I'm honored to be moderating this panel today. VBC has a way with specialty care and look forward to a really rich discussion. Specialty care providers increasingly have had the opportunity to manage total cost of care for their patients, which is leading to more affordability and improved quality of care. We've seen some challenges, of course, in terms of making that shift. So I'm really excited to get perspectives from you all on what's worked, what hasn't worked, and any advice you'd give others who are trying to transition to risk. As a reminder, please feel free to get your questions ready and submit them via the QR code. We'll leave some time at the end to review those questions. With that, I'd love to turn it over to Siobhan to start. Briefly introduce yourself.
Hello all. Happy to be here. Thanks for having me. I'm Siobhan Rary. I'm the Chief Health Officer at Oncology Care Partners. I am a physician by training, and I focus on endocrine oncology and clinical practice. Prior to my current role, I was the Chief Medical Officer of Clinical Strategy within Amazon Care within Amazon. I've been in the digital health space for over 15 years, and Oncology Care Partners, we are a purpose-built, value-based oncology care company where we leverage technology to provide high-touch, high-tech, wraparound services to patients, and including care delivery within the brick and mortar, within the four walls. We are excited about moving into the value-based care space where we are enhancing the patient experience, enhancing or improving patient outcomes, and really lowering the cost, unnecessary costs. So excited to speak more about what that entails at Oncology Care Partners. Thank you.
Good afternoon, everyone. My name is Samir. I'm a practicing gastroenterologist on faculty at NYU, also the co-founder and chief medical officer at Oshi Health, which is a virtual first GI practice, 100% virtual, 100% telehealth. Started my career more on the academic side, measuring outcomes and costs in GI as an academic researcher. Got pretty disheartened by the fact that we'd publish papers, present at conferences, and nothing would really change. So hopped over to the entrepreneurial side and have really enjoyed it. So excited to talk today about VBC in a condition area like GI, which is not what people traditionally think of as something that's approachable with a virtual or telehealth approach to care. Also not a specialty where there is a lot of value-based or accountable care.
Hi, everyone. I'm Jay Taylor. I'm the Chief Growth Officer at Brave Health. We're a 100% virtual outpatient mental health provider. We focus on serious mental illness and maternal mental health. Our business is primarily in the Medicaid space. By way of background, I've been in the healthcare technology field for almost 20 years and moved into care delivery recently, and excited to talk to you guys today about what we've been doing in the value-based care space and where we see some of the challenges.
Good afternoon. My name is Amy Jen. I'm a nephrologist by trade, and I'm the clinical leader for DaVita's value-based care programs. Prior to that work, I was a practicing nephrologist for about 16 years, and I had experienced DaVita as a dialysis company. But for the last almost 4 years, I've worked in their integrated care programs, and I'm happy to say that we've been leading the way in value-based care for over 10 years. And we care for 80,000 patients and collaborate with almost 2,000 physicians. And so my passion is to guide our physicians and really strengthen our partnerships in this world of value-based care, as I was recently in their shoes. So I'm happy to be here today with my colleagues and Lauren.
Great, wonderful. Well, as you can see, we have great representation today here across multiple specialty areas, and really excited to dig in. We're going to start talking about some historical barriers that have been faced by specialty providers in adopting VBC models. We've seen a wave of value-based care companies emerge primarily focused on primary care across the senior population. Jay, perhaps you can kick us off here by discussing some of the challenges specialist providers face as it relates to VBC models that have been explored previously, like bundled payments, given your time at Enlace Health.
Yeah, I think really the biggest challenge is making the assumption that there's one solution for specialty care from a value-based care standpoint. Just like there's not one type of specialty care provider, we really need to look at different ways of value-based care delivery based on the specialty and how care is delivered within that specialty. Bundled payments is a great example that works very well when you have a fixed start and end date for care, and you can stratify patients by acuity and have a good way to estimate what that cost is going to look like. This works very well in orthopedics, where you know what a knee replacement is going to look like, a shoulder replacement is going to look like. We have a start and end date, and the care is pretty homogenous across the population, and we can easily stratify members into low, medium, and high acuity. When you start to look outside to more of the chronic conditions, like many of these on the panel deal with today, it becomes much different, right? You can't put bounds around mental health, right? And when we get into specialized care, which much of care delivery is moving in that direction today, it gets even more complicated, where now we can't have 3 strata for patient acuity. Now we've got hundreds or more, and the individualized care can't be bucketed to say that patient 1 looks very similar to patient 2, and we're going to deliver that care in the similar way. Their genetic makeup, could be, or the way they consume care could be very different. So, using things like episodes of care just doesn't work in that type of setting. So we really need to look, just as we look to the specialist for their expertise in care delivery, we also need to look to them for their expertise in the financial system that best works for the way they deliver care, the way they manage patients, and how the variation between that care actually is in real life.
Great, thank you. Siobhan, what have we learned in the oncology space about what worked and didn't work with the original oncology care model, and what, if any, barriers are you still seeing with the enhancing oncology model?
Absolutely, I can talk to that a little bit. And just for the audience to make sure everybody's on the same page. So the oncology care model was a model started back in 2016 by CMMI. It was a model that looked at a payment structure to promote value-based care in the oncology space. It was a 5-year pilot program initiated by CMMI, and a number of learnings came out of that, which were then applied to the enhancing oncology model, or the EOM model. Now, with the EOM model, that went live in about July of 2023, and what we saw, or what we have seen over time, is that there's significant, I would say, barriers in implementing that model. So EOM was based on some of the principles that were gathered and learned from the OCM and were applied into the EOM model. It expanded the number of cancers that were receiving value-based care payments, and had a number of specific stipulations that I think ultimately are leaving practices in a bit of a struggle. So right now, many of the practices are citing about 3 different barriers to adoption of the EOM model. And to give you a sense, initially the participants were about 70, 60, 67 participants. And within the first 12 days of the launch of EOM, there were a number of practices that dropped out. And I think now it's about 30 practices, so half of the practices have dropped out. And most of what the barriers are with the program and implementing it is threefold. The first is there was an immediate need to now take on downside risk for the oncology practices. And just by contrast, when we were looking at the OCM model, we had about 3.5 years to move to downside risk. We were okay with taking upside risk for a matter of time while practices were getting more comfortable with the payment structures. But the EOM model wanted a more advanced structure, and almost too advanced for a number of practices in their infrastructure. I think the second is the onerous reporting of the current structure, and unfortunately, there was a significant decrease, almost half of the service payments, the monthly service payments, and so when those participants were in the initial OCM model, they were leveraging those monthly payments for technology infrastructure, as an example, for that reporting. And then the third common reason that's cited as one of the barriers to adopting this EOM model and this structure is around the risk adjustments. The risk adjustment model is a model that looks at normalization of patients. And in the oncology space, it's very challenging. One, there's a rise in the drug cost, and that wasn't taken into account in the risk-adjusted model. And two, patients are, it's very rare, even in large academic centers, that you would get a kind of a normal distribution of cancer patients. They're very specific based on cancer type, molecular mutations, disease type, stage. So there are a lot of nuances that may not be taken account for in the payment structure. So a lot of practices are having challenges with the CMMI structure, and I think from our standpoint, Oncology Care Partners is not within the EOM model, and we are moving directly to risk-bearing PCPs and payers to establish those risk-bearing contracts for a number of these challenges. I think ultimately there are a lot of learnings that CMMI can take away and hopefully will help to improve the structure moving forward, so more practices in oncology can take on risk in a more systemized way. So that provides a little bit more about some of the barriers that we've seen in oncology with these structured programs.
And I'd imagine some of these themes will show up in other specialty areas. Some are unique to oncology, but we'll probably see similar challenges across the spectrum. One of the big pushbacks we're hearing is that payers are shifting a lot of their risk to PCPs and don't want to have separate risk contracts with specialists for fear of paying for risk on top of risk. Samir, what have you and the team at OSHI heard from payers, and how are you getting around some of these challenges?
Yeah, the attribution challenges and attribution stacking is a challenge, and I don't have the answer or the solution to that. It is a large challenge. I think what we found, and to circle back on what Jay said, is you really have to take a specialty-specific approach to designing the type of risk that makes sense for a particular patient type. In condition areas like oncology or nephrology, where the percent of the all-cause cost that's attributed to that specialty, is so high, it makes sense to create, these all-cause risk-bearing contracts with those specialty providers. In GI, the percent of costs that are attributed to GI are around 50 or 60% for our patients. So it doesn't necessarily make sense for us to model our approach to value-based care in an approach where we take on risk. And so we like to take on the approach of bundled case rates. And, the bundled case rate model for us, it helps us prevent any sort of abrasion between us and the primary care group who might own the risk. And it makes a lot of sense for a specialty like GI, where you have both episodic needs, GI bleeds, endoscopy, but you also have chronic longitudinal concerns as well. So, we can't really mimic what happens in orthopedics with a bundle. But we also we're not in an area where we can take on all-cause risk like we can in oncology or nephrology. So for us, we take this bundled case rate approach where a percent of our fees are guaranteed and another percent are at risk for certain utilization and quality targets. And that works really well for our health plans. It allows us to create an approach that's more accountable in a specialty that's all fee for service. And it allows us to take an approach that's easy for them to implement in their current infrastructure, right? We don't work in Medicare Advantage, so this isn't a model that can work in commercial health plans, and it allows us to really do things quickly. We don't want perfect to be the enemy of good. We work with a lot of health plans that conceptually we're aligned on taking on more risk, but just administratively it doesn't work in their model to be able to subcap something like GI, where we're not going to take all cause. You've got a lot of complexity with regards to the mixture between ICDs and CPTs, and creating a model that that doesn't have a pre-existing bundle from CMS or CMMI, like Siobhan was talking about. You really need a specialty-specific approach.
Super helpful. And I'll open it up to the others here, just in terms of what you're hearing from payers, how you've had to kind of tweak or adapt your contracting to meet the payers where they are.
Yeah, I mean, we certainly have to deal with that quite frequently in BH. We see very almost all the time that risk has already been parsed out to ACOs, PCPs, and now if we want a risk-based arrangement or non-fee-for-service based arrangement, quite frankly, then we need to look at contracting with those PCP or ACO groups that are already taking on risk, which in theory could work great as long as they're looking at it from the right angles. And I think there are certainly some ways to look at that. And the more forward-looking PCP groups and ACOs will look at their total book of business, see these specialties where they're excelling, and there's going to be some loss leaders in that book, right? And if they should be looking at what are the loss leaders that we have, and how can we fix our risk in the areas that we're underperforming, push the risk off or have the risk go to somebody who's willing to take it, the specialty group that's interested in that now they've reduced their cost, reduced their risk, and given the risk to someone who actually wants it. I mean, I think that's a perfect solution to that problem, but we need to find PCP groups and ACOs that are willing to accept that that's what they're doing and willing to look inward to see where are our loss leaders and where should we be, putting those dollars to work somewhere else.
Yeah, it's a good segue. Amy, I'd love to talk to you about barriers you've seen in the market around aligning the incentives between PCPs, payers, and specialists. And please chime in after Amy.
Yeah, alignment is so important. I mean, we're all trying to do value-based care. You can see everybody has a really different approach. And so, as we do that, we have to be very careful not to step on each other's toes and to make sure that we're rowing in the same direction. I think there's a lot to celebrate. We have seen in the kidney space our physicians really start to change behavior to provide much higher quality care than they were before, thinking about the value-based care world. And yet, I mean, make no mistake, it's hard to be a nephrologist in this day and age. It's hard to be any specialist right now. And what we're seeing is that even those that have embraced value-based care kind of have their legs in two canoes, one in the fee-for-service canoe and then one in the value-based care canoe. And that makes it very difficult when your patient population is split in such a way. Mm-hmm. And also, Siobhan, you were saying the onerous structure of some of these programs, it's hard for them to fully embrace a program when only a small fraction of their patients might be sitting in that program. So it's incredibly important. The need is there to align across the board so that we can start to do these things at scale and really get programs where we can have a lot of our patients within value-based care and try to get the nephrologist at least leg out of the fee-for-service canoe to drive the population for improved outcomes.
What's been very challenging for us in GI, I'm somewhat jealous of nephrology and oncology, where you have this tops-down opportunity and there is an existing carrot, so to speak, to provide to a nephrologist or an oncologist. And companies can come in and say, hey, look, there are these existing accountable contracts and we can help you achieve better outcomes or demonstrate cost savings, demonstrate the quality of care. In other condition areas, there are no existing frameworks, right? So that carrot does not exist from the payer or the government-sponsored plan. And even if it were to exist, I think when we start to design, these incentive frameworks, we have to be very upfront about the fact that, a $20,000, $50,000 incentive payment is going to drive a stronger behavior change in certain specialties or for certain practices than they are for subspecialty procedural areas where that may just not be a big enough carrot, right? And so how can we start to think about alternative ways to change, provider behavior, practice behavior? A lot of, subspecialty practices, and, you mentioned this, it's really hard right now to be a clinician. You've got, rising operating costs, downward pressure on your fee-for-service reimbursement, and a lot of these practices just have bigger fish to fry, right? They're interested, they want to kind of dabble in these contracts, especially in areas where there isn't much VBC or accountable care, but they're more worried about making sure their infusion centers are going to be able to keep the lights on. And so these are the sorts of things that in a specialty like GI, where there is no tops down framework for VBC, there are a lot of challenges in getting that alignment.
I would add to really what many of you have already said, which is, especially in the oncology space, I think we're seeing a lot of pressure in general where we know, I think with the advent of a number of treatments and increase in access, that cancer patients are living longer. And so it's becoming more of a chronic condition or a chronic disease. And there is that need to have that longitudinal perspective. I think that bodes well for partnering very closely with the primary care doctors. And what we have seen is bringing them to the table, recognizing that the costs within oncology care right now is about 6% of the GDP, the estimated U.S. GDP, and is only expected to increase, between now and 2050 to about 15%. So a large amount for employers, for providers, for the healthcare system. It's a huge undertaking in the oncology space, and so aligning with the primary care doctor and having them at the table, understanding their pain points, not only the pain points of the patient, has been very beneficial. And we have created integrated programs where we integrate into the workflow. And so we have this very easy button, if you will, for the primary care docs to refer over to oncology or to have that seamless experience for the patient, given the status quo at the moment is a very fragmented system for patients who are going through oncology treatment. Siloed records, locked in places where it's very challenging for patients to navigate, let alone the PCP to navigate. And so being able to provide solutions to the issues that providers are facing and patients are facing has been fairly beneficial for us. And it's that collaborative environment that helps with care coordination, with navigation, with referral management, and all of the soft side, if you will, to provide that holistic patient care for the oncology patient. But I think it can be translated to really any chronic disease where you are looking at the longitudinal survivorship of the patient.
Yeah, and I was going to say, not to make Samir more jealous, but Siobhan and I kind of have a similar population and some similar challenges. As we've been able to partner way upstream from the dialysis population, which I'm sure is where you all think of integrated kidney care with kidney patients. And we've been able to go upstream and partner with our primary care partners to detect early chronic kidney disease and really start to forge that relationship with them. So it is pretty amazing that you can take a patient population from early disease, maybe even prevention of disease, and create a value-based care program that takes them right through to end of life. And I know this is much more challenging for the part of value-based care that you all are in, but to start to connect those episodic dots so that we end up getting this sort of comprehensive picture of the patient, I think is our challenge as a medical community.
Yeah.
Great. So I actually just want to build on a lot of we're talking, but shifting gears here to spend some more time on the infrastructure and processes necessary to make value-based specialty care successful. I'm curious, what tools, data, and infrastructure do we need in place to enable payers and primary care providers to incorporate these new payment models for specialists?
Well, we do shoulder a lot of that primary care work ourselves. So we work with them and we shoulder some of that burden. So I like to think of our IT and tech department itself when I think about this. And it really is led by clinicians. So it's led by the end user, which is phenomenal. And as they start to challenge this very complex environment, they're thinking about two things. One is using AI to create risk models so that we can pinpoint those vulnerable points in our kidney patients' lives, be able to deploy differential resources to them so that we can really impact their care for those who in the greatest need. And then the second thing that they're doing is really thinking about what platforms we can use to deliver patient care, which is incredibly challenging. We all know that there is a ton of EHRs out there. There's a lot of apps. We certainly don't need another password, right? So having this team of AI and tech experts led by clinicians it's really challenging work. And I think it's incredibly important that we get it right. Because the clinicians need a dynamic platform to be able to care for these longitudinal, patients, really from soup to nuts. So, as challenging as it is, it's incredibly important, and I think our trajectory is getting there. It's good.
And I think underlying this whole thing is the data transparency component of it. I mean, everything that you're saying is things that we need, but we really can't get there without, especially as specialty care, with only a subset of the data that we have access to. When you think about PCPs, ACOs, or the payers, right? They have access to all of the claims history. As a specialist, the larger percentage of the care that you're taking on, obviously, the more information you have, but there's still a big difference, and there is still a tremendous amount of data that's happening outside of our primary care practices. And without that data transparency, which some payers are very forthcoming, they want to work with the specialist to help deliver better care, make sure that they have all the tools from a data transparency standpoint to ensure that better care is being delivered. And then other payers are guarding it with their lives. And the last thing they want to do is share data with us because they're worried we'll use it against them to negotiate contracts and show better care. But ultimately, the difference in us being successful in value or not is going to be, are we working against each other or are we working collectively? And I think this exists both on the primary care side as well as on the specialty side and really on the payers. I mean, the payers need to share that information with the PCPs that are bearing risk so that they know which specialist they should be referring to and who's performing with higher quality, lower cost. Without that, the PCPs are left blind of knowing which specialist they should be working to and who they should be directing patients towards. So, underlying all of these components and things that we need from a platform and tool perspective is that access to data, which, can have all the best tools in the world. If we don't have the data to supply it, it won't mean anything.
Building on that answer, I totally agree, but I think collaborating with the payers who own that claims data is so important. And I'll give you an example. Claims data is just a nomenclature, right? It's a language we use for billing. And we use that as a surrogate marker to identify complexity, acuity, risk modeling, things like that. In novel condition areas, it's really, really important to work with specialists who practice because they're aware of the incentives the end user has who are using that data, right, billing in our notes to potentially obfuscate or maliciously or not maliciously code things in different ways. And I'll give you an example. We've run analyses with our payers where we ask them how much they're spending on something like IBS, and the number comes in very, very low, much lower than I would expect, having looked at costs in this field for almost a decade. And when we look at what they're doing, they're only looking at costs where IBS is in the primary condition area, irritable bowel syndrome. Well, if a patient who has IBS goes to the emergency room and gets a $10,000 workup, none of that is coded as IBS, right? It's all coded as acute abdominal pain. And there's multiple of these types of examples where, if you're working, they're mostly working with actuaries. And so if those actuarial analysts are not working collaboratively with the specialists and the clinicians who actually know, hey, when this code is actually being put on a claim, it might mean XYZ. It's not probably meaning what you think it means. It can obfuscate a lot of the data and a lot of the costs. So data transparency is definitely important, but we've been very fortunate to have fairly collaborative relationships with the actuarial teams, with the health plans that we work with to help unravel where that cost obfuscation is.
I would add to that thread of recognizing that data is king. However, I think all data is not equal, right? So we have claims data, which obviously there's a significant lag, 6 months or even longer. But then we have a significant amount of data in the EHR that either is real time or even the real world evidence or the real world data that significant amount of patients are wearing or tracking on their own. And so my hope is that especially with value-based care, when we're aligning the incentives across the board, including the payers, the providers, and the patients, that we can have an opportunity where the data is interoperable and the data that might be unstructured is structured in such a way, leveraging AI and predictive analytics and multiple technology-facing platforms and tools to unite this data and really be able to have that longitudinal patient view. And not only longitudinal over time, but structured data 360 degree, especially when patients are out of the clinic where they spend the majority of their time. And so again, that's my hope, that's my goal. As we're moving into this value-based care space, I think it's an opportunity that we can really seize the moment around.
Great, and actually building on somewhere, Samir, that you started to go, I'm curious tactics or strategies you all have for others on getting attribution for populations, successfully carving them out, showing a strong ROI to payers. And I know you're all doing slightly different types of risk arrangements, but curious if you could provide any advice.
Yeah, happy to give a little advice from my perspective. I think clinical validation is a pretty obvious one, but payers are getting more and more sophisticated in evaluating the data that providers are putting in front of them. It's an opportunity, but it's also a challenge. I think one of the things that is frustrating about virtual subspecialty care is the fact that we have access to a lot of data because a lot of what we do is digitized. And because we have that data, payers want access to it. If I were to go and just open up a gastroenterology practice in Soho, New York, no payer would ask me what my outcomes are, what my costs are. But if I want to do that in a virtual setting or a value-based setting or design any sort of accountable contract, all of a sudden all of this data becomes very, very relevant and important. So having prospective clinical trials that we've published has been very valuable. Learning to project manage the enterprise sales process for the payer has also been very helpful. So unfortunately, we have some battle scars now at Oshi that have come in handy. When we go to a conversation with a payer, we know and we can predict, so we can start to parallel process and say, look, you might want to get your actuarial team on board. Here's the ROI questions they're going to be asking. Here's the ICD, CPT, NDC code set that we use. Here's the file. Go give it to them, get them on board. You're probably going to have to get your medical director team on board, set up these meetings. And so, payers are big, they're complicated. And so sometimes the people you might be talking to, the stakeholder you might be talking to, may actually not know that is the sales process. And so being able to project manage that sales process from our perspective has sometimes made it a little bit easier, whether it's an employer sale or a health plan sale.
Super helpful. And maybe Siobhan or Amy, you can speak to attribution models or carve-outs and how you're working with payers to ensure that those take place.
I think the attribution model, especially in the oncology space, probably similar in the nephrology space, is very complicated. I will say, when we're looking at the more upstream patients, so even suspicion of cancer is where we're moving towards and where we're going. And if you can imagine, attribution model would be vary depending on the patient specific stage, the disease type. And if we wanted to be very sophisticated, it's the molecular markers. We're not there yet, but we're hoping to move in that direction. And the only way that we can get there is fully understanding that longitudinal patient view with the specific data to understand the total cost of care for that specific patient population. So for us, it's working very closely with the actuarial team, who has experience, if you will, in complex modeling in a way that we can then take it to the payers or even the risk-bearing PCPs and show them or guide them along in the process for how to create that attribution model. But I do think it's varied and it's different depending on the specialty, which makes the process that much more difficult.
Yeah, I agree, Siobhan, and it is a very complicated structure. And I do think that for nephrology, the nephrology world, we've been able to really get upstream. So even early CKD disease, and these are patients that do have, more than 3 comorbid conditions and more than 4 providers. And so being able to show that you can follow them for a very long period of time, gain trust, and be able to make an impact in all those important events in their life, those high cost events, you're able to show that ROI. So in the full risk model, which we have, majority of our programs are full risk models. We have the luxury of being able to do that and really being able to just carry that patient through all the way to end of life. So it is, a little bit of a different model than what we see from Jay and from Samir. But I think that's where you're able to show ROI in what you do.
Great. So before we take some questions from the audience, I'd love to just end on a fun one. We're going to go around and have each of you share a prediction around what you think will happen over the next 5 years as it relates to transitioning specialty care to value-based contracts. Siobhan, do you want to go first?
Sure. I shared a little bit, but I would say my hope, rather, in the next 5 years is that we are developing or leveraging technology, developing tools that will help the patient, the provider, and the payer, and really that is working with the AI-based tools as an example to provide that predictive analytics so we can intervene earlier in the course of treatment, in screening, figure out the right patient at the right time who would benefit from this particular screening, all the way up until treatment and survivorship or end of life with early palliative care. And so leveraging predictive analytics to help us to do that, but also AI-based tools to help with decreasing the administrative burden, to help with really creating a model where patients from many different aspects, whether the data is in the EHR, in the real world, or part of claims data, you are able to have that seamless approach to the patient, especially oncology, where precision medicine is extremely important and will become even more important. And so you're really able to provide that precise information to the patient that's sitting in front of you and improve that individualized care. In my mind, I like to think that AI is leveraged in a way to supercharge the medical oncologist or to supercharge the clinician to allow them the time to be able to have that face-to-face experience with the patient, but all of that data is crunched in a way that there are specific clinical decision support tools at the point of the patient.
That's a great answer. I think what I'm most excited about is a culture shift, a cultural shift. All of us are slightly biased just by the very fact that we're here at this panel. But value-based care doesn't have a positive connotation across all of medicine. To a lot of clinicians, it's just a buzzword to represent a new form of managed care or a new way that companies are going to get between them and their patients. And you're starting to see that change, but very, very slowly, of where clinicians are actually starting to be trained at the medical school level about things like financial toxicity and resource allocation. And, if we do something unnecessary to this patient, that takes away care that's possible that we could give to someone else, right? That thought process has not really been the way we've been taught as clinicians. And so as that culture starts to shift, I think it'll unlock a lot of possibilities in accountable care and value-based care.
Yeah, and I think building on that, the specialist needs to be brought to the table in designing what these value-based care models are that apply to that specialty. We should be able to follow the exact same model that we're doing in care delivery, right? The PCPs and the generalists don't make decisions for the specialists. They go to the specialist for a reason. We can replicate that model from a financial delivery model with value-based care. And the specialist should be at the table when there's the design for the model that makes sense for their specialty. And when we do value-based care a disservice when we paint with a broad brush and we say, every certain percentage should be in value-based care, great. And maybe that'll work for the ones that fit within the existing definitions that are here, but not every subspecialty does, and we really need to define what that is for each subspecialty and make sure that those specialists are at the table when that's being defined. And there are tools that we can use while we work to get there. It's great if those episodes of care already exist and we can use those models. It's great if some of these specialty care areas fit into a total cost of care model. But there are mechanisms in like a pay for value type arrangement where it may not be as sophisticated, but a payer, a risk-bearing entity, and provider can mutually agree on some metrics that are important to the person that's holding the risk, and something that the specialist can deliver on and be accountable for, and then mutually agree on what the financial incentives are for that. And start small, because ultimately it will drive better outcomes. It will drive both of you getting what you want, and is a good placeholder until you do have those more complex systems in place.
I'm hopeful over the next 5 years, but we have to get to scale. I mean, it just needs to happen, and we can't do it alone, which apparently we're not. I mean, we have a lot of people interested in this aspect of medicine. I believe that if we get the specialists to the table, we continue to have physician collaboration, we align the incentives, which we talked about earlier, I think the next 5 years could be very transformational. I think we're truly at an inflection point right now in medicine, and it's really incredibly exciting to see. But at this point, we all have to come together and create, these populations that will move in the right direction. So I'm very hopeful.
Great. Okay, I'm going to read a few from the audience here. For ACOs that already have specialists in your areas of expertise, how do you navigate the topic of augmenting versus replacing their medical groups in negotiations?
I can take a quick stab. We don't work with a lot of ACOs, but we work with a small handful. And one of the value propositions that we discuss when we work with them is we deliver services that they're not able to deliver, right? So gastroenterology, GI doctors are very, very busy treating patients with GI bleeds, taking out cancers. They do not have the tools in their war chest to see patients every 2 or 3 weeks, provide them with unlimited access to a dietitian, provide them with access to a GI psychologist. And so, there's a common misperception that, value-based care means you can't be in fee-for-service. There's also a common misperception that if you work with a VBC subspecialty provider that, you're going to take business away from your brick and mortar incumbent specialists. There are ways, and I think hybrid care delivery is actually the right way forward. So it's just around complementary care, between visit care. Those are the value props, and that's what we've actually proven in our clinical studies as well.
We see something very similar in the behavioral health side where access to care is a huge problem. So, it's not about taking away, it's supplementing, right? And if your problem is access, then, adding additional providers certainly isn't a problem there. And again, very similar to what you're dealing with in GI. There's populations that can't be served, right? I mean, we focus on serious mental illness where not every outpatient provider is interested in taking on high acuity schizophrenia, bipolar, major depressive disorder. So, if they want to focus on lower acuity, then that's great. And we can help and augment that on the higher acuity side.
Great. Do any of you now participate in downside risk?
We are moving to participate in downside risk. I think it's important. It's the evolution of value-based care, and I think we've focused on various aspects where you can have your fee-for-service, you can have your bundled payment or your shared savings, you have your upside risk, and then you have your downside risk, which is total cost of care. So I do think evolutionarily it is an important step to get there. And there are mechanisms and structures that are important to put into place in moving towards that risk.
Yeah, agree. We do participate in downside risk. I will say that the difficult thing is getting the physicians to start to participate in downside risk. That is something that they're really just trying to wrap their arms around this whole concept. And again, because it's a smaller population of their entire practice, it's hard to get them kind of to take on that. But we're getting there. We do have practices that have started doing that in some of our value-based care arrangements. So, we're just chipping away at it.
Great. And maybe we'll take one last question here, probably a big one, but what role do the social drivers of health play in value-based care for the complex patient population you see in specialty care?
I mean, I think one of the most exciting things about these accountable contracts where there's, changes in billing innovation and billing architecture is it allows you to actually address some of these social determinants of health. Because now you have a fiduciary responsibility to do that. Whereas in traditional fee-for-service, it's very challenging to impact that sort of aspect of one's health. In our model, if a patient with cirrhosis has trouble getting access to high-quality, low-salt food, in my brick and mortar practice, if I have time, if I'm not running behind schedule, I can do my best to try to help that patient. But in our model, because we're accountable for the outcome and we're accountable for avoidable utilization, we can actually really allocate resources to try to fix those structural challenges. But I don't think it's a panacea to solve all those problems.
I would add to what Samir is suggesting, where I think the exciting part of value-based care is that you can focus on social determinants of health and provide those services, those wraparound services to help decrease hospital utilization that's unnecessary, decrease unnecessary emergency room visits, decrease hospital readmissions, because most of it is around access to care or access to a number of these items, especially in the oncology space where, we're asking for, in cancer, we are making you sick before you can get better. We're asking patients to disrupt their entire life and not only focus on treatment, but it's the side effects as well. And we know, in a very predictive way, the highest risk of what time point you're going to have the side effects or what type of nutrition is important for you to, decrease side effect management or to improve and extend care. And so for us, focusing on value-based care and looking at the savings associated with these services allows us to reinvest dollars into these wraparound services like nutrition or like specific oncology-based behavioral health to provide this more holistic approach to our patients. So I think when we are moving towards value-based care, it allows one to focus on whole person care, which incorporates looking at the social determinants of health.
Great. All right. Well, we are at time. So thank you so much to our panelists and to everyone in the audience. I hope you have a wonderful evening and enjoy the rest of the conference.
Thank you.
Thank you.